So hello, my name's Ed.
And my name's Johnny.
And this is episode 5 of the Surgical Discussions podcast series. This is going to be quite a brief podcast on the spleen. During this podcast, we're going to talk a little bit, first of all, about the anatomy of the spleen. We're then going to look at some of the conditions, hyper and hyposplenism. We're going to talk about splenectomy, and finally have a brief look at splenic trauma. So I'm going to start by talking a little bit about basic anatomy. As always, Johnny, if I get anything wrong or...
I'll just dive in.
Dive in, go for it, correct me.
Will do.
So, the spleen, large organ of the lympho-reticular system, about the size of a fist, situated in the left upper quadrant, specifically under the 9th, 10th and 11th ribs. Vascular supply is important here. There's a massive artery called the splenic artery, which comes off the celiac trunk and enters into the hilum of the spleen, as shown in this diagram here. Important relations. Anterior relation is the stomach. Posterior are the ribs and the diaphragm. Medially, you'll find the left kidney. And laterally, you'll find the colonic flexure, specifically the splenic colonic flexure. Function of the spleen, most useful to think of this in terms of the various hematological functions and immunological functions. The little diagram here illustrating the way it enlarges from the left upper quadrant to the right iliac fossa, and also that you should percuss from this region as well. So,
okay, splenomegaly.
We don't like splenomegaly. Well, I don't like splenomegaly.
There's quite a lot of causes, but we'll classify as always. So there's massive, which is greater than 8 centimeters enlargement, moderate 4 to 8 centimeters enlargement, and tip, where just the tip is palpable, which is less than 4 centimeters of enlargement. Always remember that important causes are myeloproliferative disorders and lymphoproliferative disorders. So I might bang on a bit about that.
As always.
So, causes of massive splenomegaly, myeloproliferative disorders.
In particular, there's one that causes
CML.
CML, not a nice condition.
Myelofibrosis,
Yep.
And 3 tropical infections, malaria, leishmaniasis, and the brilliantly named Kala-Azar.
Kala-Azar. And leishmaniasis, that's visceral form, isn't it?
Yeah.
Rather than cutaneous. Okay.
Okay, moderate splenomegaly, 4 to 8 centimeters, once again, myeloproliferative, and also infiltration, either amyloid or Gaucher's.
Gaucher's, another eponymous syndrome.
Yes.
What is it?
I think it's a carbohydrate storage disorder.
Lastly.
Okay. Tip splenomegaly, once again, myeloproliferative. Also congestive disorders, so portal hypertension, excess use in hemolytic states, and other infections, so infective endocarditis and Epstein-Barr, which we'll come on to later, but may cause a splenic rupture. So, hyposplenism.
A little bit easier, actually.
Much easier.
Much easier.
We can divide it into iatrogenic, so this is usually asplenism due to a splenectomy, or autosplenectomy, so hyposplenism, decreased size of the spleen. This can be divided into hemolytic causes, such as sickle cell later in the disease,
Yep.
or inflammatory causes, so lupus, vasculitis, celiac, or ulcerative colitis.
Okay. So, I'm going to talk a little bit about some of the investigations you can do if you were to find splenomegaly or suspect involvement of the spleen in a disease. As always, we go through our 5 sets of investigations: cultures, bloods, imaging, scopic stroke biopsy, and functional. The important cultures are blood cultures, for example, in infective endocarditis, one of the causes of tip splenomegaly. You might have positive blood cultures. The ABG is not so useful in this situation, but there are lots and lots and lots of venous bloods to think about. Things like FBC, we might find a raised white cell count in infections. We might find evidence of hemolysis. Also, U's and E's are important, obviously signs of ill health, signs of dehydration, etc. Also, other inflammatory things, so we want to do a CRP and ESR. LFTs, as always. We might want to think about doing a blood film because of malaria. And finally, we might want to think about doing various immunological blood tests, as vasculitis can cause splenic pathology. Important imaging modalities include abdominal X-ray, ultrasound, and abdominal CT scan. The abdominal CT scan is particularly important in the context of trauma, which Johnny's going to talk about later. Now, the scopic stroke biopsy investigations, you can't really do any scopic investigations. I suppose we could count laparoscopy as an investigation.
Yeah,
maybe.
Could do.
But biopsy-wise, because of all the involvement of lymphoproliferative and myeloproliferative, as Johnny was saying, you might want to think about doing a bone marrow biopsy if you suspected these conditions. Lastly, and probably least importantly,
it's more your own knowledge.
It's quite nice. It's quite nice science. Chromium-51 red cell scan can be used after a splenectomy, particularly when the spleen has been involved in a malignant process, to look for ectopic foci of splenic tissue. So that's really the spleen investigations. I'm going to move on now to talk about splenectomy. So why did we take the spleen out?
Tell me.
The most important cause, which actually is your responsibility, is trauma. The most common other reason for taking the spleen out is due to the fact that hyposplenism, often as part of, say, ITP or hereditary spherocytosis, has caused derangement in blood parameters or hematological complications. Often these are not wanted. For example, platelet rises causing strokes and emboli and clotting and all that kind of stuff. So the only way to really deal with this is to get rid of the spleen. However, there are two other important causes to be aware of. These are splenectomies where there's been surgery around the spleen, say to the stomach, or as we said earlier, the splenic flexure of the colon, and the spleen is damaged in some way, and therefore may need to be removed. Also, it may need to be removed with primary splenic lesions, which include tumours, abscesses, splenic artery aneurysms, and cysts. The procedure itself. There are two basic options. You can do an open splenectomy or you can do a laparoscopic splenectomy. Obviously, in the emergency setting, you're going to want to do a laparotomy to get at the spleen. And in an elective situation, you can do an upper, middle, and left subcostal incision. And there are the two scars there. So, complications. As always, we can divide these up into early, intermediate, and late. Obviously, the early ones, apart from things due to the general anaesthetic, you can have bleeding, because of course the spleen is a very vascular organ. You can have sepsis associated with the surgery. And you can have left lower lobe atelectasis. This is the most common manifestation. The other thing to be aware of is thrombotic complications. There may be a paradoxical rise in platelets soon after splenectomy, often with platelet counts going quite a bit above 1,000, and obviously this is not desirable, and patients may need to be treated with antiplatelet agents such as aspirin. Intermediate complications include pancreatitis and subphrenic abscess, and the late complication, another very important complication, is infections with encapsulated bacteria. So, after your patient has had a spleen out, need to be vaccinated against encapsulated organisms. The important encapsulated organisms are pneumococcus, meningococcus, and Haemophilus. You use pneumovax against pneumococcus mense, against meningococcus, and Hib against Haemophilus. Patients also need prophylactic penicillin, usually for life. So, eel versus splenic flexure.
Indeed, splenic trauma. So, mechanism of the injury can be through penetrating trauma in a rib fracture, or blunt trauma, so non-penetrating. Can also be iatrogenic, so in colonic surgery, or it can be a spontaneous rupture, as we've mentioned previously, in Epstein-Barr infection.
Or sometimes relatively minor levels of injury. There's an important point there, isn't there, that minor levels of injury often present quite late.
Yeah.
This is usually because, as you said, the spleen is very vascular, but if there's only a minor tear, you can get a hematoma forming underneath the capsule of the spleen, which will enlarge, and then finally burst and cause the signs and symptoms sometimes to be aware of.
So, can be classified into types 1 to 4, and this guides your management later on. So type 1 is just a capsular tear. Type 2, there's a capsular tear and parenchymal injury. Type 3 is up to the hilum, which we saw earlier. And type 4 is complete fracture of the spleen. The clinical features are obviously of left upper quadrant tenderness, and due to the large vascular supply, they can be shocked or hypertensive. There's also some eponymous signs. So Kerr's sign is pain in the left shoulder tip, and the balancer's sign, which is shifting dullness in the right flank.
And we don't know what causes that.
No, unsure as.
Once again, if anyone knows, please let us know.
So here you can see a complete fracture of the spleen,
which is going to need treatment.
Splenectomy.
Yep.
Right, so management. Type 1 and 2, as always, we can split it into conservative and surgical.
Okay.
Type 1 and 2, as we said before, was either a capsular tear or a capsular tear and parenchymal injury. So for this conservative, things like analgesia, fluids, blood, and adequate monitoring. And then for more severe trauma, so type 3 and 4, you can do a laparotomy. This could be partial or total splenectomy. And in children, you want to preserve as much of the spleen as possible to protect from encapsulated bacteria infections.
Yeah.
So,
okie dokie.
With you?
Yeah. So that's basically it. At the end of quite a short podcast. It was quite a short topic, spleen. But we've talked a little bit about the anatomy, where the spleen is. We talked about that dirty grey blood vessel supplying the spleen. We talked about clinical characteristics of the spleen, how to tell it from a kidney particularly, and how to describe it in the examination.
That would be embarrassing in the exam.
Hyposplenism, as we said, Johnny said, divided up into massive, moderate, or tip. Remember that myeloproliferative and lymphoproliferative can cause all three. Hyposplenism, we talked about the two big causes, i.e. iatrogenic and autosplenectomy, secondary to either hemolytic states or inflation. Inflammation, yeah. Splenectomy, why do we do it? Usually because of trauma or because of hematological complications of disease. And how do we do it? We can do an open operation, we can do a laparoscopic operation, and try and remember those two different scars. Finally, under splenic trauma, we talked a little bit about the 4 types of splenic trauma and how these are managed. So that's it for the spleen. Thanks for listening. It's goodbye from Ed.
Goodbye from Johnny.
Bye-bye.